introduction here. Hey, everyone. Hey, those of you that are coming in early, thank you. And it's great to have you join us. We'd love to hear feedback from anybody out there. If you could put it in the chat box, some of your visions of good health equity or examples of health inequity. Today, our discussion is going to be around health equity and health literacy, and how some of the issues that are out there can be addressed by implementing certain types of health literacy services and information. But Al and I do not see all the different programs out there, and we're not running a health plan. So we would certainly like to hear from the audience. And you can put this in the comment section, and we'll try to weave that into our conversation today. But any good programs you've heard about that address health inequities, or if you have examples that you'd like to share with the group of health inequities that are not being properly addressed by different programs out there, by all means, please, we'd like to keep this an open discussion. So please feel free to join us in this conversation by adding to it. We can see people coming into the webinar here. We're going to get started, just after the top of the hour here, which is only a couple minutes away. So thank you, everybody, for joining us today. I think you're going to find what we'll present today very interesting, in the sense that there are certain things in health, in improving health equity that can be addressed by a particular method of health literacy education on specific topics. But we want to make this a discussion today. And if you have any comments or information you'd like to share about programs that you've seen in action that are really improving health equity for employee groups, we'd love to hear about it and share that with the group. Or if you can share any inequities that you know about that exist that need to be addressed, we'd also like to share that with the group as well. But we're going to get started here in just a couple of minutes. It's the top of the hour right now, and we're just going to give people a chance to come on in. We do have a fair amount of people that have already come in, and we thank you very much for participating today. Al's going to lead our discussion, and I think we'll be presenting some pretty interesting stuff that might move the needle in improving health equity in the employer groups that you work with.
Good. If I could just add, we have a lot of polling questions, and there's gaps in the polling when you're doing the polling. So if you folks don't put stuff in the chat box, we're going to have to put on the Jeopardy music when you're doing the polling. Mark, the other thing I need to add is that my green light is on. The camera is on, and it's not going through. I just don't know what to tell you.
But we're seeing your screen, which is great.
Yes, that's the important part. And frankly, I don't look so good. So want to kick?
All right. Well, I think we're about ready to go here. I'm just going to start, and thank you again, everyone, for attending. And we welcome any comments, thoughts, feedback that you can put into the chat box as we may have this discussion. We really welcome that. But I'm going to start by just making a quick intro about what we do in addressing poor health literacy. And general, what this means is that employees are not understanding or using their benefits properly. They end up spending too much of their own and the plan's money in the medical marketplace, and they get roped into a lot of unnecessary and potentially harmful tests and procedures, which are rampant in today's medical marketplace. So we address this with a creative quiz structure. You can see there, that's actually Al when he was on Jeopardy, and we put a lot of humor and trivia in the quizzes that we put out once a month that take about 10 minutes to do. We get a 92% completion rate. We got doctors at Harvard Medical School reviewing this material, so it's believable. We have, at this point, 1,800 questions. A lot of these are benefits related to help employees understand their benefits. And now, in addition to that, what we have now is a point of service application. And there's a strategy involved in this that helps employees not get large bills from the ER. And that's still a big problem all over the country. And Al will talk a little bit more about this particular strategy that we have set up so that's right on people's phones. And then in addition to that, on the application that's on people's phones, we've got 180 odd categories of doctor visits. So it solves the issue of people walking out of the doctor's office thinking, oh my goodness, I should have asked that question. There's information about the visit. There's questions to ask, questions you might get asked from the doctor, how to prepare. It's really good stuff. So that's also part of Quizzify. So you wouldn't necessarily think of health literacy in combination with health equity. And Al has done a fair amount of research to prepare for this. So I think you'll be pleasantly surprised as we walk through this. And we want to hear from everybody with questions and chat box. So please try to contribute. Thank you. And without further ado, here's Al Lewis.
Yeah, hey, thanks, Mark. So we're going to ask you to put some stuff in the chat box right away. We have just a couple of views of health equity that seem to be similar to other folks. Our view of it is that everyone in the same situation gets the same care, same attention, same offerings, regardless of socioeconomic circumstances or race. Now, Justin Leader, who some of you I'm sure know or are familiar with because he is a leader, small l, in this in the benefits field, put it very well. He said, the recognition that some individuals or groups need an extra boost to reach an equal outcome. So if you have anything you'd like to add to that, just put it in the chat box. So we're going to do the first poll right now. So be ready to hit your buzzer. Mark's about to put it up. What is the impact of health equity initiatives on your overall health spending? A noticeable increase, no real impact, a noticeable decrease, or you don't know? And Mark, I cannot believe we'd have anything in the chat box yet, but do we?
No, nothing's come in yet.
Okay.
See, we've got Q&A here.
All right, well, let's turn on Jeopardy music for a couple secs. Do, 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 do. Still kind of painful to me because I lost. All right, what do we got? Don't know. Yeah, well, looks like you're in the majority, my friends, because a lot of people appear not to know. And frankly, we hope to get and it seemed like it was fairly equal amongst the other decrease and increase. So let's see what happens at the end. We're going to re-ask this question. So we're not experts on health literacy. What we are, I'm sorry, we are experts on health literacy. We're not experts on health equity, but we are experts on the intersection of health equity and health literacy and saving money. And that's what we're going to show you today, is how some strategies in health that are designed for health equity can actually save you money. We're going to go through 6 of those. You can see them on the left. And we're going to say it'll be red, yellow, green scheme. What's the current health disparity? Can we address it? Can you save money by addressing it? And how easy it is to implement. And we're going to start with colon screening, which if those of you who are on our last webinar, remember we did a lot on colon screening. We did not address it from this particular viewpoint. It is a large health disparity in colon screening. Now you might say, how could that possibly happen? Well, first, just to put it in context, we do want people to get their colon screens. Colon screening is probably by far the most effective of the major screens in avoiding the cancers associated with the organ being screened. So the question today is not whether we want to screen, it's how you screen equitably. There are 2 disparities that we're going to ask you how familiar you are with them, that happen in colon screening. One is the time off required to get a colonoscopy. And you can Google on time off from work and colonoscopy, and these are some of the things we got. 34% of people missed work on more than the day of the procedure. It is recommended you take the day off of work. You will need to take the day off from work. Some people work evenings, take the day off before as well. So people are losing work time, which is not an issue for the salaried population, but for the hourly population, it is an issue. So the question is, and lawyers, when they cross-examine witnesses, they always know the answers in advance. I have no idea what the answer is going to be here any more than we did the last time, which is why we're doing the polling question. Do you compensate? Oops, I'm sorry. It's the next question mark. We took this one out. Do you compensate? Let's X out of that one. Do you compensate hourly workers to get a colonoscopy beyond any standard incentive that you have? Yes, no, yes, but they have to go through a process, or you don't know. And remember, don't know is fine. As we see, don't know seems to be a pretty popular answer these days. So the question is, do you compensate? Mark, anything in the chat box yet?
Not yet.
All right, well, let's see what the,
Here we go.
okay, no, see, that's a health disparity, because it's actually costing people more who are hourly than who are salaried to get a colonoscopy. Now, how does Quizzify? So a disparity number 2. So that's one disparity. Disparity number 2 is some employees may not know, or it's possible you may not cover alternatives to colonoscopies. Now, those of you who were on a webinar last month may remember this slide. I'm not going to go through it all. There are different ways of screening colons. I will point to the bottom, though. No pun intended, although if I had, it would have been a good one. Colorectal cancer deaths averted per 1,000 40-year-olds. The numbers are fairly similar for colonoscopy, FIT. This is not used anymore, the virtual one, because of the radiation. And this is Cologuard over here. So these all are in the low 20s. So they actually work pretty darn well without taking the day off from work. And now here's how Quizzify pitches in. So we teach people that they can get, I'm going to call it an almost as good colon screen, although I myself am perfectly happy getting one of these myself without taking time off, without doing prep. And that is 100% covered, if in fact you do cover it 100%. And here are 3 things that people may not know about. The FIT, which you can do in the privacy of your own home, as you can with Cologuard, or next time you happen to be at the doctor, there's when they're drawing blood anyway, there's a blood test for colon cancer as well. And people don't know about this, and it equalizes the amount of work time required to be taken off. Okay, next, let's look at premature delivery. Now, premature delivery sort of goes arm in arm with the fertility benefit. And I'm going to postulate that, that you do not pay for time off for hourly workers if they are trying to access the fertility benefit and need to go to the doctor on a fairly regular basis. If that's not the case, put something in the chat box. We'd love to hear about it. But we're going to focus on premature delivery, where once again, a huge health disparity. And once again, green, 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 quite easy to address, especially with Quizzify's help. Now, this stat is pretty well known. It's from the March of Dimes, and it shows a fairly dramatic difference in premature delivery by race. And preterm birth is not just sort of a little thing. It actually is a major driver of healthcare utilization and cost. Full disclosure, these next 3 slides come from a vendor called Sarah Prognostics. Quizzify generally does not endorse particular vendors. This is an exception because they are the best. They're the only ones who do what they do, and it's a lot of money, and education helps a great deal. So preterm births, your Medicaid, you probably have to multiply these by 5 for commercial, cost 10 times as much as full baby births do, and they drive the large majority of your newborns. If in fact, newborn costs, if in fact you have a stop loss coverage and you look at your stop loss claims, you're going to see a lot related to the beginning of life every year. This preterm product will, if you do it, it will take you from the typical 17% of pregnancies that you're able to identify as being potentially premature using conventional methods to more than 80%. which is huge. And all you have to do is cover it and know how to use it. And here's the impact that you get. Now, I will tell you, because remember, we're not the vendor here. We're Quizzify, so we're pretty objective, although the vendor would tell you the same thing. This preterm company does not make much of an impact at all on taking babies all the way to term. It makes a dramatic impact on taking very premature babies and turning them into slightly premature babies. Very dramatic. And that's where the money is, my friends, right there. So the question is, I think about 20% of employers are covering this at this point. So first, do you cover the preterm test? And Mark, I noticed we do actually have some stuff coming in. Okay, so while you're doing that poll, let me answer the question that's come in. The difference between the colonoscopy and the almost as good is one catches the issue before and the other tells you have cancer. That is absolutely true, but here's the big difference. And this is why, now remember, we're still saying colonoscopy is the gold standard, but this is why we're trying to get many more people to do some kind of screening, right? But the thing that is not in this question is that you do the other things much more often. So you're doing a colonoscopy every 10 years, and that's the U.S. Preventive Services guideline. These other tests are being done every year, every 3 years. So that is why they are almost equivalent to the colonoscopy. If you were to do Cologuard or FIT every 10 years, it wouldn't come close to the screening value of the colonoscopy. So what do we get for do you cover the preterm test? Okay, so basically just very few people. A lot of people didn't answer actually. Well, you should is the bottom line. So we're going to do one now, whether or not you cover it. Do you compensate hourly workers for doctor visits and lost work time related to high-risk maternity? And Mark, do we have anything else that came in?
Well, maybe a question about, can you elaborate a little bit more on how this preterm test actually works?
Yeah, so you go to the doctor anyway at week somewhere between week 19 and 20, and that turns out to be the sweet spot for getting this, and you're going to get your blood drawn anyway, for getting this test done on drawn blood. And it looks at certain proteins in the blood that are predictors of high-risk maternity. And so you can be at a sort of a average level below, or sometimes, 5 to 7 or 8 times the average, in which case you should be getting a very intensive prenatal premature birth avoidance program that's going to require a lot of your time. So that question segues right into this poll. So what do we have for this one? Okay, you have another health disparity here that I'm impressed that one company does cover the time off. But I think what we learned is that there's actually an ROI in covering the time off for people who really need this. Now, where does Quizzify come in? Well, we have 3 prenatal health literacy quizzes. The first is the basics that some people might not know, like stay away from cat litter. The second is things to learn while you're pregnant. And to use the example of preterm, assuming you cover it, we teach people why they want it. And third, approaching due date, you're not supposed to clean the babies off. That turns out to be just wrong. And you're not supposed to detach the umbilical cord right away. And a significant minority, if not majority of hospitals are still doing both of those things. We teach people to ask for the opposite. All right, next, drug adherence. Once again, a huge health disparity. We're not really in the drug business, so we're not in the drug business. So there's not a huge amount that we can do here, but it does save a lot of money and it is easy to implement. Drug adherence is very clearly linked to race and income. And I'm not going to go through all this stuff, but you can just Google on those things and see what you get. And it's not a surprise. So how do we deal with drug adherence? Well, I'm going to use my own example. So I typically would go through my wife's health plan, which has a $18 copay for generics. And I was getting my Ambiens, my generic Ambiens. And I will be the first one to say, I am addicted to these Ambiens. I do love my Ambiens, and I sleep like a baby every day, every night. And I was paying $18. And then I met a guy from Drexy, Bill Miller, who gave me this Drexy card. And so I started paying $3.25. Now, this was 2020, early 2020, almost 3 years ago. But now with inflation, instead of paying $3.20, I'm paying $2.99. Okay. And I think that's probably because they merged with AMP, so they have more purchasing power now. But the bottom line is that you can use an AMPS Drexy, a GoodRx, a ScriptCo, a Southern Scripts, any number of things. But these two in particular, you can do on a transaction basis, meaning you don't have to sign your life away. You can still have the PBM contract. And by transaction basis, what I mean is that, let's say I didn't have a Drexy card. I wasn't a member of Drexy. And I just wanted to get the value of it. I could pay $3 extra each time I filled my Ambien scripts for $2.99. And by the way, even though you've gone outside the PBM, this still counts against your deductible, and the usage still gets tracked by your PBM. So this is my usage, and there's a lot of drugs here because I just had a little minor surgery. And I would just focus you on these absurdly low prices, number one. And number two, this is coming to me from Optum RX. This is not coming to me from Drexy. So they are tracking and putting this stuff against my deductible. So the question is, can your employees get a better deal than a big PBM offers? Yes, and we've told them about it. Yes, but they don't know about it, so they use our PBM and pay a sizable copay after they meet their deductible, which is what I used to do. Our generics copay is already very low with our big PBM, and obviously we're paying the balance, or we already use an alternative PBM. So anything come in here while we're waiting?
Here's one. Do PBMs track the use of alternative sources, and does that getting counted against your drug deductible?
So I gave my own example for that, but so I think the question is just in general. I think it's a great question. I'm going to tell you that I think the big PBMs do, and the reason I think the big PBMs do is I have gone, ballistic with Optum and told them to stop tracking my stuff because I don't like Optum. I went to a different pharmacy so they wouldn't know who I was when I started using my Drexy card. And I told them to cease and desist, and yet they still track it. So my suspicion is that somehow this is built into the system and you can't get out of it. Sort of like that Seinfeld episode where Elaine was a difficult patient and all the doctors found out about it. So what do we get for the answer here? Okay, so this is actually the most even one we've had. They do get a better deal. We have told them about it. They don't know how to use they don't know how to use it, but they could. That was where I was. That you basically subsidize a very low copay, or you already use one of these alternatives. And by the way, we've got quite a number of people on this call. You're allowed to vote, even if the answer is you don't know. We're getting very low turnout, sort of like the odd year of a election when the mayor is not even on the ballot. So how do we help here? Well, this isn't like the others where it's kind of a night and day using Quizzify thing. We do teach employees about the value of generics. It's not as useful as you think it is because the name brand drugs are offering these copay coupons that actually are illegal in my state. To try to get around the fact that generics are less expensive and they don't want the substitution. You have a unique benefit, and we can certainly customize our drug Q&A to your benefit. So for instance, if your diabetes meds are fully covered, which for most people with a concern about health equity, they are. And that's why in that very first question, when we asked, does health equity and a focus on health equity make your costs go up? This is an example where your cost does go up, but you're getting much better coverage. And we also show employees how to do exactly what we do, which is use these alternatives that, as the polling question said, are already available, but people tend not to know about them. So the next is the dental benefit, which of course is one of our favorites, where there actually, once again, a huge health disparity that I will be surprised if people have taken note of. It's very addressed by Quizzify. You know, it saves some money, but dental's not a big expense, so this is yellow. But once again, very easy to implement. Now, the reason that dental is a big thing and there's a big health disparity is that you are covering 2 visits for everybody. You know, that's the classic person with the feet in the oven and the head in the freezer being average. Some people do need 2 visits. Some are perfectly okay with 1, but the people who are going to crash on you are the people who need 3 or 4 and aren't getting them. There's a large body of evidence that you can click through on to that account. And we actually have done some work for a dental company that says, look, you know, if you encourage people to get 3 or 4 visits who need 3 or 4 visits and you cover them, we'll actually put some of our fee at risk for medical care for those people because you are going to avoid events for those people, statistically speaking. And it's more than statistical. Once again, this comes from, it's not on our look or our template because it comes from a vendor. But I actually did the work for this vendor as a consultant, where we took, this was a large manufacturer, low-end manufacturer. The average person probably was making at the time $9 an hour. Some humongous percentage of them had not been to the dentist in more than 2 years. So we took those folks and we, the ones who were willing to go to the dentist, we compared those to the ones who weren't. And in fact, the ones who are willing to go to the dentist, mind you, the same population, people who are dental phobic, had not been to the dentist. The ones who are willing to go, their medical expense went down very substantially versus the others. So the question here is, do you fully cover a 3rd cleaning or checkup for people who need them? Yes. No, because we didn't think of it until now. No, because we don't believe dental has value, or we don't know. And Mark, I suspect other questions are coming in because I can see my screen lighting up at the top here.
There was one comment about, you know, someone said, I understand there's some significant inequities surrounding sickle cell disease.
Yes. Now, sickle cell is pure health inequity because it only affects Black people, sickle cell disease. And there are new drugs that are very effective, far more effective than the old ones, and yet they are priced very high. So this is a classic pure health inequity. And in fact, if you go to drugs.com, which is like the Rotten Tomatoes for pharmaceutical reviews, and you look up these drugs for sickle cell disease, it's heartbreaking to see the comments, just heartbreaking. This was working really well, and then I couldn't afford it. That's the comment that you're going to get all the time. So this is one where health equity does cost money, but if you read the comments, you're going to want to cover the drugs. So what do we get for this answer? No, oh, this is why people join our webinars, my friends, because you didn't think of it till now. Now you're going to do it. And I'm actually quite impressed that a few people are already doing it. What I'm not impressed by is how many people are not voting. Now, we are not going, we probably every 2nd or 3rd webinar figure out some way to work in our obsession with silver diamine fluoride for cavities into the webinar. And so those of you, stop me if you haven't seen this before, but this stuff you put on the tooth with 1 drop, no drilling required. So you put on something called a micro brush here, and then the dentist brushes it right on the cavity and it stops the cavity right there. And then you don't have to drill out the healthy enamel to create a little hole to put the filling in. It also, this is my own EOB. I have it in my own mouth. This is like the Cy Sperling and the Hair Club for Men. You know, he's not just the president, is also a client. This is how much I paid. It was not covered by my wife's insurance coverage, but I would have had to pay 50% of a cavity, which would have been twice as much money to get it filled. And I was in and out in 2 minutes. You know, it worked better than we say it does. So the question, and I hope we get some yeses on this, because we've been talking about this stuff forever, and we get about 50% same people on all of our webinars here. Do you cover SDF at 80% so that hourly workers can get their cavities treated at low cost and with less work time? And Mark, I see some more stuff coming in here.
We had a comment about this deductible and using like an alternative source like a Drexy card or a Good RX. And the comment is that from Carolyn Grant that the deductible will only apply for an HSA or a plan with a prescription deductible. And I think a lot of the plans now do have that prescription deductible where you've got to pay a few $100s, you know, before your copays kick in.
Yeah, no, I think that's right, and all the more reason to use the alternative. Okay, so let's see if people are covering this. Oh my goodness, folks! When you listen to our webinars, do you like put us on mute or something? You've got to cover this stuff. If you write to us, we'll give you the codes. It's very easy to cover. It's 2 codes. Okay, so now let's get to, I would be lying if I didn't say this was our favorite part, because it involves Quizzify directly. And in fact, next month, we're going to do a more in-depth webinar on these topics. Doctor visits and ER costs. Saves a lot of money. I'm sorry, Dressed by Quizzify. This one saves a lot of money. This one is just going to make your employees happier. And once again, very easy to implement this stuff. This will surprise nobody. Then what surprises is there's only one study on this. The time spent per doctor visit by race of the patient, a significant health disparity. You know, they say that you get 12 to 15 minutes in a doctor's office. Well, apparently that depends what race you are. So how do you make those doctor visits more effective, and how do you squeeze those 15 minutes out of them? Well, if you go online and you ask that question, you get the exact same answer from everybody, which is prepare and make a list. Prepare and make a list. Don't forget to ask questions. Make a list. ... That is not particularly helpful if you don't know what questions to ask. So we, Quizzify, provide those questions for 187 topics in our doctor visit prep kits. We also say, if you're reluctant to ask, blame us. So let's actually go live to the prep kits here. And we have, as mentioned, 187 of them, essentially anything you can think of that is a first doctor visit or a common procedure or a common drug, we've got it covered. And what happens is you enter a keyword right here. Just put in back. All sorts of different back pains, low first visit, low second surgical, upper middle. Let's go with low first visit. And what you get is now think of yourself now as you're a sophisticated buyer. Think of yourself as an unsophisticated buyer of healthcare services. Think of how valuable this is to know a few things about it. One of the things we say at Quizzify about the back pain is 80% of back pain will go away on its own, but 80% of back pain sufferers are convinced they are in the other 20%. We actually think it's more like 90-10, but whatever it is, people tend to overtreat their backs. And then many of you probably offer some kind of musculoskeletal special benefit here that maybe your employee doesn't know about. One of the big complaints we get in Quizzify, not a complaint, it's the reason people hire us, is can you teach employees about our benefits because they don't know about them? So this says, check the benefits, take the quiz. We have a back pain quiz down here. I won't click through on it. And then we have the questions to ask the doctor and then what to expect from the doctor. And then you can click through on any of these links, and we also have carefully curated sources for more information on this topic. You can add it to your calendar. I'm not going to click through because I'm about to exit this slide. And we're going to go into some detail on this in the next webinar that we do next month. So this is a virtual coach, care navigation right in the doctor's office, which is most valuable for people who don't have good sophisticated experience with health care. We also, actually, I think I need to click through here. We also have this very similarly for ER visits. And some of you may be very familiar with our ER sticker shock prevent consent. I think many of you are. It now comes with an explainer video and an ER billing quiz right in it, so that when you go to the ER, you don't have to have sort of, memorized the information. By the way, you don't need to memorize it anyway, because guess what? It's all geo-fenced, so that when you go to the ER, and in my case, these are the closest ERs in drive time. If you go to the ER, it will pop up basically as soon as you're within about 50 feet of it. And I know it works, not just because I know it works, but because, don't ask me why, but there's a bike path that goes within 50 feet of an ER. I mean, of all the places not to put a bike path, right? But every time I'm on that bike path and I pass the ER, I hear the little ping in my saddlebag telling me that this thing has popped up. So once again, I'm not going to go into this in detail because we're going to do this next month. But we teach people how to get a much better deal in the ER than they are getting right now. And if somebody thinks they can stare you down and you're going to back off, we have a 24/7 number. We also have a rebilling number in case they send you the wrong bill. So we've got your employees back. Now, the funny thing is I just saw this. There's actually now sort of an HSA for ER for emergency medical stuff. And people are signing up, companies are signing up to fund these HSAs for emergency medical stuff instead of just reducing the price of emergency medical stuff, which would seem to me to be much easier. So how do we help here? And what is this? Well, we basically just shown you, and once again, stay tuned for the next month's presentation. We're coaching people on what to prepare and what to ask. We're showing them what the visit should look like, because we don't want you to get moved along. I mean, nobody's really pushing you out the door, but you can kind of tell your time is sort of running out if the conversation sort of slows down. We don't want you moved along until your questions have been asked. And then we have new features coming soon on this that we're going to cover in next month's webinar. And really, this is the only navigation system for the actual doctor visit when you're in the actual doctor visit. So we're not a care navigation company, but this is care navigation in the visit. Imagine a clinical conversation guided by a GPS. That's what we have. We're making every visit, if you use the Quizzify to Go doctor visit prep kits, are looking like the best DPC visit. Now in the ER, the reason that we're saving all this money is that ER bills are very high, and this is a great cartoon. I mean, they're high whether they're out of network or in network. I mean, what no longer happens is those surprise bills that make the headlines. Those are gone. But even the in-network bills are very high. And generally, it's the states with the highest uninsured populations that have the highest ER fees. The reason is that when the providers are negotiating with the payers, first of all, the payers have much more negotiating leverage when they're talking about electives that they can send anywhere, total joint replacements, normal deliveries, whatnot. And second, the providers will say, well, in the ER and for emergency admissions, we have to let anybody in. So, and we need to cover the costs of people that we can't collect from. So we need to charge more to people we can collect from. So typically, if you look at the states with the highest uninsured populations, they have the highest ER costs, with Florida being number one, and you've got Texas right up there, and Nevada's up there. I mean, just the ones you would expect, except New Jersey, which has more than average insurance coverage, and yet has the second highest ER rates in the country. So this is the exception, but it doesn't matter where you are. You will be paying 200% of Medicare, which is what we do, regardless of whether they're marketing it up to 400% of Medicare or 2,000% of Medicare. You're paying 200% of Medicare. There is absolutely no reason why you should be paying this much. I just basically talked through this slide. But what I didn't mention is the name of the law that makes this happen. It's called the Emergency Medical Treatment Act, Emergency Medical Treatment Act of Labor Act of 1986, where they have to eat the uninsured costs. So the bottom line is, this is truly the ultimate health equity solution, which is just everybody pays lower costs, not just the people who can't afford it. Everybody pays lower costs. And this is very important because the amount of medical debt, the amount of worry that people have about unexpected medical bills is huge. I mean, you've all seen the statistic that the median, not the average, the median American does not have enough savings to cover an ER visit. Well, guess what? Now they do. I mean, it's still going to be, it's still going to be, a financial hardship, but it's not going to be like a bankrupting thing to pay $800 instead of $2,000 or $3,000 for an emergency. So our proposal is very simple. Let's reduce the cost of emergencies, and we can guarantee them to be under $1,000, except for procedures done in the ER. That involves, Medicare reimburses considerably more for that, both to the physician and the provider. So as a result, we can't keep those under 1,000. But actually, in dollars, you're going to save the most money on those. So why not simply reduce the cost to make them more affordable to wage earners, and we'll take care of the rest. I just teased that next month, this is what we will be covering. So let's have a final polling question. I noticed there are quite a number of things coming in on the chat box, and we do have 5 minutes, so this is timing out very well. All this stuff costs $1 PMPM approximately. It could cost a little bit more if you're a small group. It could cost considerably less if you're a larger group. But let's just say $1 PPM. Now, remember, this was the first question that we asked. We asked, what is the impact of health equity? What could be the impact now of health equity initiatives on total health spending if you do these things that we talk about? Now, the winner before was don't know, noticeable increase. I think actually noticeable increase was first. Don't know was first. Noticeable increase was second. So let's see if the numbers change. Mark, what do we have? Yeah. Okay. So we moved the needle, folks. Still not getting much of a turnout, but this is what we tried to accomplish here, was to show you that health equity, leaving aside the fact that it's an end in itself, makes a great deal of business sense. Now, Mark, the questions have kind of piled up, and we do want to end right at 1:45 or 45 minutes after the hour.
Yeah, there's one really straightforward one. Yes, Quizzify is available in Spanish as well as English. Yes. Those are the languages that are currently available. And there's another question here about a comment that SDF leaves a discoloration. Is that our experience, and does it fade with time?
Oh, that's a great question. Yes, SDF will turn the decay black. There's no question about that. In fact, when I show people, I wish my camera worked. When I show people my SDF, I open my mouth and I point to my back left molar and I say, see, you can see it because it turns black. And I say, well, I don't really care because number one, it's my back molar. And number two, I don't have to press anybody anymore because I'm already married. Now, if it's a kid's tooth and it's going to fall out anyway, and kids get a disproportionate share of the cavities, then honestly, you're not going to mind if it turns black. Or it's on a molar, as adults tend to get them, and then you're not going to mind. But also there's something called potassium iodide that the dentist can put on top of the SDF that will very substantially lighten that blackness. Now, it won't fade it all the way to white, but it will considerably lighten it. Now, also, if you do that, your economics, still better than filling a cavity, but it's not dramatic like it was in the example that we showed. Anything else? We got 2 minutes.
Well, in general, there is a question about the pricing. The pricing of $1 per employee per month, or $12 an employee a year. Does that include the Quizzify to go, the doctor prep kits in the ER, as well as all of the question content?
Yes, what it does not include is if we have to do the rebilling, and you may, I just showed it briefly, and I'll show it again next month. A lot of times what happens is the people go through the steps, but then because most ER bills are billed kind of there's an assembly line, a process that goes on for billing, people might not notice in the ER that you completed this prevent consent, as we call it, and they send you the regular bill anyway. If you send that to us to get it rebilled, we're 100% successful at it, but we're gonna charge 25% of the savings. But otherwise, yes, everything is included.
And another question here is, how can I tell that I'm actually realizing some savings by implementing this strategy of educating people to do the things and the content you talked about today?
Well, that's very easy, actually, because let's take the 2 examples we just talked about, which are silver diamine fluoride and the ER. Silver diamine fluoride has codes that are associated with it. You just count up the codes. And let's say you had, you have 1,000 cavities in your group. You maybe had 5 with SDF last year, and this year you have 100. Well, we get credit for 95 multiplied by the difference in the cost between SDF and the cavities. In the ER, we're saying that we're keeping all the bills that don't have procedures on them under $1,000. So you can look at the bills now that are under $1,000, and let's say 5% of them are under $1,000, and now it might be 20% next year, even with inflation. It might be 20% next year. We get credit for the 15. So it's actually vastly easier to figure out if Quizzify saves money than it is to go through all the machinations that that wellness vendors and diabetes vendors will put you through.
And just also note, we do have an open ROI calculator. It's in the more section of our website on the top menu. So that's also something that if more and more employers now have their data, and you can actually put the data in there and actually run a calculation on our website. There's a couple other elements of that we didn't talk about today because they didn't relate directly to health equity. And there's another question here, Al. Were you actually on Jeopardy, and what date was it?
Yes. And people ask me if I won, and I say, I always say, yeah, I was on Jeopardy once, and people ask me if I won, and I say, let me repeat, I was on Jeopardy once. You can actually still find it in the Jeopardy archives, not the tape, but they have the transcription of the show. I actually got more answers right than the champion did, but he bet better than I did, I have to say. And the date was, I think it was March 12th, 1987 or something like that. All right, I think on that note, I think we're all done unless there's any other questions. Going once, going twice. Well, this was great, except for the fact that not a lot of people voted. It was a great session, and thank you all for attending.
Thank you.